And good morning. It's time now for the Elder Law Report for this Friday, the 29th of April, 2016. And with us again today on this Friday as usual, here is Greg McIntyre. Good morning, Greg.
Good morning, Milton. Good morning, listening audience. It's Friday once again. I can't believe it. This week has gone so fast. This month has gone so fast. April's almost gone. We're getting ready to get into, what, May flowers, right?
April showers bring May flowers.
Right. So I need to see some flowers coming up in May. So, hey, we've got a great guest with us here today. We have Sybil Huggins here. We're very honored to have Sybil Huggins, who is an RN, BSN, CCM, and ACM. Lots of letters behind her name with Carolina Healthcare System. She's a discharge planner with Cleveland and Kings Mountain Hospitals. Okay? And maybe a director or manager over that department, over the discharge planners, and has been a nurse for 22 years. Is that right?
That's correct.
Is that all?
That's all.
I'm only 21 years old, so you've been a nurse for longer than I've been alive. No, I'm much older than 21, but that's a long time.
It is.
You're pretty good at your job, I imagine.
I like to think so. Yes.
Okay. Tell me, I mean, you've got all these qualifications and degrees already, and you're also working on your master's degree right now. Is that right?
That's correct. Going to Queens College at this time, online program.
Right.
And I'll be doing my clinical at Cleveland when it comes time. Just kind of broaden my education and broaden my options.
Well, it's about time you started doing something with your life. You've only been a nurse for 22 years and have 4 other degrees. So, yeah, so you're doing that at the same time that you're managing the case manager.
Yes.
Yeah, or the discharge planners.
Yes.
At the hospitals. That's very impressive.
Thank you.
So we're very glad to have Miss Sybil Huggins with us today. And discharge planners, I mean, you might think out there, well, what do discharge planners at the hospital have to do with the Elder Law Report? Well, let me tell you. Many times discharge planners, and we'll get into this in detail, they're dealing with families and patients who are rolling into perhaps home health care, assisted living care, or nursing home care. They're at the forefront of deciding what level of care a patient needs. And oddly enough, when that's determined, lots of times our office, a family may contact our office in those types of situations to say, hey, how can we best handle this, protect assets, and maximize healthcare options? Or they'll contact our office well before that ever happens, which is desired, and do pre-planning to make sure they go ahead and have in place their healthcare powers of attorney, general durable powers of attorney for personal business, living wills, and wills. And that's what we call foundations. And I'm going to talk to Sybil. I'm very interested to get into that and how those powers of attorney and those other foundational documents factor into the job she does. Because I happen to think it probably makes it a lot easier if the patients have already put in place those items and directed someone in the family, a trusted family member, to be the point person to communicate with the hospital, especially for healthcare issues. So Sybil, welcome to the Elder Law Report today.
Thank you. Glad to be here.
Glad to have you here. Glad to have you here. So we've already gone over how much of an expert you are. Okay, tell me a little bit about. Now, did you start off just as a nurse, or just maybe working in the hospital, taking care of patients, and then moved into discharge planning?
Really, I started out as a CNA in the hospital. I went to school and got my degrees and graduated to RN. Worked on the unit as a floor nurse or staff nurse for many years, and then I transitioned into the charge nurse position. And then after several physical problems, I realized I could not continue that. But I had been doing some PRN work for the case management department And I just kind of just naturally transitioned over to that because I did not want to give up my one-on-one personal experience with the patients. I still wanted to be involved in that caring for those people. And so this kind of fit the what I needed to achieve. And so I transitioned over to the case management. I worked as a staff case manager, discharge planner for 6 years, and now for the last 3 years I've been the manager of the department for Cleveland and Kings Mountain.
Okay, very impressive. And for all the listening audience out there, I want to tell you this is a great chance to learn about how, a loved one or yourself would be dealt with if you had a care need coming out of the hospital, and to look at how Medicare pays for health care when you go to a hospital visit or have to transition to either in-home, nursing home, or assisted living care. And we're going to really start talking about that here shortly. So without further ado, let's say someone goes to the hospital. I go to the hospital, heaven forbid, okay? But I have to go for an extended hospital stay. And at some point, the hospital may not be the best place for a person to just stay. The hospital is not meant to be a long-term care facility or a place where someone stays indefinitely. It's meant to be where we stabilize someone, right, from a medical emergency. And there comes a point where we have to look at what's next.
Correct. And that's, I agree with you wholeheartedly about the pre-planning. That's, it makes the work that we do so much easier. If you've already got a power of attorney, if you've got a living will, all those things that play into placement. Because when it comes time and people are in the hospital, they're in a crisis situation, and it's hard to make decisions. And then if you've got 4 of the 5 family members and they're not in agreement, those papers really come into play when we're trying to find out who is ultimately responsible for making a decision if you're not able to make that yourself. So when you come in and we find that you cannot go home safely, then that's where discharge planning comes in. We at the hospital see everyone that comes in within 24 hours of admission. And in that process, we ask about probably 60 to 70 questions related to anything between finances and your social life and who you got to support you in your time of illness. So in that process of asking those questions, we determine if you may need some services once it's time for discharge. And if you're able to speak on your own behalf, then of course we speak with you about what you might need and how you're going to get it paid for. And then if you're not, then we speak to the family members. And anything we plan, we make sure that we keep in constant contact with you or the family and make sure that everybody's in total agreement with that, because we're not making plans that you're not in agreement with, because the patient and the family have the final say-so. We always say that we want a safe discharge plan, but our discharge plan may not be your discharge plan. Just because we think something is feasible, or we think that that's what you really need, you have the final say-so as agreement. If you do not agree, then we have to go with whatever you decide is your discharge plan.
Right. Absolutely. Absolutely. So I imagine having that one person designated as a healthcare power of attorney to communicate with you as to the plan for a loved one. Does that make it much easier to decide, or do you have situations where you have multiple family members who want different things?
We do come into situations where we have multiple family members that are wanting different things, and sometimes it's just totally opposite of one another. They're not even on the same page, and that's where those documents really come into play, especially that healthcare power of attorney. That's the person, that's the contact person, that's the point person that ultimately has that decision. And hopefully they have spoken with the family and the patient, and gotten a good feel and good instructions and solid instructions about what they wanted at the end of life, or what they wanted if something happened and they couldn't make those decisions themselves. And so it really gives us a straight line to the person that can make those decisions.
Okay, yes ma'am, yes ma'am. So when I'm in the hospital and let's say I've come to the point where I've been stabilized, and well, number one, when I'm in the hospital, let's talk about how Medicare pays. I know there's an observational stay, and then there's an admittance, right, where I'm admitted.
That's right.
Now, how does Medicare decide when it's going to pay and when it's not going to pay?
There's two basic, you have all kinds of rules and regulations that Medicare have, but the two basic ones that we go by are the 2 midnights. You have to be in the hospital 2 midnights, and that's a new rule that Medicare has that's been implemented in the last couple of years. Plus, you have to have medical necessity. If you don't have both, then you don't meet inpatient qualifications. You cannot have one and not have the other and be appropriately inpatient. So that throws you back to an observation status. What that means is we're expecting you to not be there any more than 48 hours. And that's the expected turnaround. And of course, you have to meet medical necessity for observation, but that's not as tough, or it doesn't take as much criteria to meet observation as it does inpatient. And financially, there is a financial impact no matter which status you're in. With Medicare, you have a deductible, and that is it. And if you pay that deductible and you're admitted inpatient again during that same year, you don't have that deductible to meet again. That's a one-time deal. With observation, each time you come into the hospital, you've got the deductible, and then you've got to remember this is outpatient services. So you've got a deductible, and then it's 20% of the charges, and that's with each observation admission. So that's the difference in the financial impact.
So, what happens when I'm rolled into an admitted patient? When you formally changed me from observational status to admission?
That it just rolls you into an inpatient status, and then that puts you into the one-time deductible. And then Medicare pays for the hospital stay.
Okay, yes ma'am. And then, let's say I'm at the point where I am stabilized, but we have to decide how I'm going to be discharged, or I'm going to be discharged. But then after I'm discharged, that's where the discharge, or as I'm being discharged, that's where the discharge planning comes in. That's where you and your team really get involved and decide where I need to go. Is that right?
Not really.
Okay, you tell me.
The discharge starts at the time of admission.
Okay.
So what we do...
so we don't wait until I need to be discharged. You start right away.
That is the point of trying to go in and talking to everybody within the first 24 hours, is to make sure that we have that discharge plan in place by the time that doctor writes the discharge order. We're not scrambling at the last minute trying to get services in place or places for you to go at the very last minute. So we say that the discharge plan starts on the time of admission. That's the reason you're asked so many questions about who you have to take care of you, what do you want as far as discharge, what do you think you're going to need, different questions like that. But that starts on admission. And so we interview you. If we don't think you need anything, we may not come back unless a doctor refers, unless there's a change in your condition. If there's a change in your condition that warrants us to come back and see you again, we will come back and talk to you again, reassess, and get those discharge plans in place. But all the time that you're staying there, depending on what the discharge plan is, whether it be home health, home with no services, or with skilled facilities, we are looking, what kind of equipment are you going to need? Where are you going to go? Who you're going to have to help take care of you? Where are you going to go? And if it happens to be home with home health, then we give the home health agency the heads up. We give you a choice of what home health agency you're going to use, and then we get those services put in place, and they're kind of like on hold. And then when that discharge order is written, then we can kind of say, they're leaving. You know, you need to go ahead and do this. With skilled facilities, we ask you what facility would you prefer. According to Medicare, they have regulations as far as that's concerned. We can kind of explain that to you, that you have to have a 3-day qualifying inpatient stay. That means that you have to be inpatient. You have to have needed to be there, had to have medical necessity. In other words, you needed services that required you to be in the hospital for 3 solid days in order for Medicare to pay for a skilled facility. Like I say, we've asked you where you wanted to go. We try to get that if at all possible. But if someone else offers a bed according to Medicare rules, and that place that you have wanted to go has not offered a bed, then we are required by Medicare to send you to the one that offered the bed. And if you refuse to go, then there are certain letters that we can issue that you would send the hospital financial responsibility, because Medicare says it has to be a safe discharge. It doesn't have to be your preference, for them for you to be able to go to the skilled facility. So all of those, when the doctor writes with a skilled nursing facility, we usually have that bed waiting on you. When that doctor writes the discharge order, then all we have to do is call the skilled facility and say they're discharged, they're expected to come today. Lots of facilities have their own transportation. Sometimes the family wants to transport, and sometimes we have EMS transport, depending on the ability of the patient, or how sick they are, or whether they can stay in a car, or whether they can sit in a wheelchair.
Absolutely, absolutely. And then, let's say I'm discharged to a nursing home. Medicare will pay, or skilled nursing care. And I know it can be skilled nursing care for a long-term or short-term stay, or it can be skilled nursing care with a rehab facility for rehabilitation. Now, Medicare will pay for the first 20 days that I'm there in full.
Yes, sir.
As long as it's a Medicare facility that also accepts Medicare.
Yes, and as long as you meet a skilled need.
As long as I meet a skilled need, correct.
Mm-hmm.
And then after that, if I have a supplement, another 80 days would be paid for, correct?
Medicare would pay for another 80 days, but
Okay.
they would not pay it 100%.
A copay.
They would, you would have a copay
Yes.
to go with that.
And then after that 100 days is up, who pays?
You would have to pay, or you would have to qualify for Medicaid.
Sure. So you have to come, I'm pulling out my wallet.
Yeah.
You have to come out of pocket, right?
Yes.
And I don't even know if I have any money in my wallet right now. Oh,
You hadn't got enough for.
I got like 33 bucks in my wallet right now.
That's
How much
not
would that
enough
pay
for
for?
skilled. That's not enough for skilled
No,
nursing facility.
5 minutes. No, a few minutes. Yeah. So it, and rightfully so. It's they provide a lot of services, and that costs money. So you're looking at average cost of stay, in my experience, in this region, okay, in Western North Carolina, somewhere around, with skilled nursing care, I want to say $5,000 to $7,000, somewhere in that range.
That's
okay?
correct.
Somewhere in that range, just depending. And that can easily, what is that? Let's say it was $6,000. Let's just say 6. That's $72,000 a year. So that can quickly spin down retirement savings.
Oh, definitely.
I know I have met, and on a regular basis, with a crying wife or a worried husband, where they maybe been through a year or two of that, and they're scared that everything they've saved for retirement with their spouse, who is requiring this care or requires this care, is going to be gone. And those are tough situations because we need to pay for care for that spouse. That spouse needs the care. But also there's the healthy spouse who has maybe another 20, 30 healthy years to live. So those are really tough situations. Again, pre-planning is where it's at. Pre-planning. Looking at if you can get it. Long-term care insurance can really, that's like a godsend when you see the long-term care insurance piece because you don't have to worry about it as much. It'll pay for generally 3 to 5 years, depending on the policy. I don't see many indefinite policies that just pay forever anymore. There used to be policies that would just keep paying out, but mostly either 3 years or 5 years is what those are capped at. We don't get involved. We're just on the legal side. We don't get involved in the insurance side. But we do work with a lot of the insurance professionals that provide those types of products. And if I meet with someone and they have the means, then I may counsel them to go talk to someone about that, about long-term care insurance piece. Because it takes away the need for you to pull out your wallet and just start paying, or go into your accounts and savings and just start paying. But once you are spent down, for a married person, the healthy spouse, just under the rules, can keep $119,220 this year. And the spouse that needs care can keep the reserve amount of $2,000. After that, after you're properly set up that way, then Medicaid would come in and pay for the rest of that healthcare stay, right, or that skilled nursing care stay.
Yes, that's the way that it works, and we encourage people as soon as we know that they need skilled facilities that they go and make a Medicaid application. And lots of times that's where they find out that they can't have assets that they thought they could have, and they realize that it may be going to impact them financially because they don't qualify for Medicaid at that point. When you come into the hospital, you're in a crisis, and not only physically, but you're also in a financial crisis at that time. And it's a little bit late in the game to worry about how you're going to pay for things because it's in your face then. So I suggest, I would suggest everybody think about, yes, you're walking around today healthy, but you never know when you're going to have a stroke, something, some kind of debility that's very unplanned. Most physical sickness or illness is not planned, and when you're in the hospital and you've got all of these needs, financial needs, it can be overwhelming. And if you've got things put in place and insurance policies, different things like that can help with that beforehand, it makes the process a whole lot easier.
We talked about on this show before. It's been a while because we've just been focusing on interviewing community members like yourself that are involved in caring for seniors and others, in different aspects. But Medicaid Asset Protection Trust or irrevocable trust that we set up for seniors on a regular basis that start that clock ticking and look back on Medicaid and allow them to portion money so that the spouse isn't so scared about that money being spent down also. And even in an emergency, I would say, if you're going through that emergency right now in that healthcare crisis, Sybil's right. The last thing you want to be worried about is, oh my gosh, Who's going to be my power of attorney? How are we going to get money to pay for this? That's why you want to have those at least foundational documents in place ahead of time. If you do, then we can do some things to position assets so that maybe you have some options there to keep some assets and also access healthcare benefits. There's just different ways to solve that problem. And I do see families all the time in that emergency where it's flying in their face and they don't know what to do. So they can call me. I'm Greg McIntyre, the elder law guy. I have a law firm that's McIntyre Elder Law. I also do a radio show and appreciate all the listeners out there and appreciate our guest in Milton. My phone number is 704-259-7040. And if you have a healthcare crisis, if you need to go over how to pay for it, if you want to get your your legal documents in place, your foundational documents in place, such as your healthcare power of attorney, general durable power of attorney, living will, and will for yourself or as a couple, call our office, 704-259-7040. One of our very competent staff will help set you up an appointment. If you call and you say that you heard the elder law guy, Greg McIntyre, on the radio, and that's why you're calling, we will waive the $125 consultation fee that we would charge anyone else to sit down and talk to. So we would waive that free of charge for you listening today. And it's been a pleasure to have our guest, Sybil Huggins, with us today, who is an extremely knowledgeable nurse and manager. And this is a much different part of nursing than a lot of nurses see, I think. What do you think?
Definitely. Most floor nurses, including myself, before I actually got into this, I had no idea what all was involved. But we are the ones that are holding the person's hand when they're having a transition to a home health or skilled nursing, and we're dealing with all those emotional problems that go right hand in hand with as well as the physical disability with the patient. And so, but I couldn't be prouder of what I do, and I love it. So I appreciate you having me.
The community's blessed to have you and all the other communities, the 16 counties, to have people like you working in their community and caring for the people in their community and seniors, transitioning them where they need to go to get proper health care. So thank you very much for all you do, Sybil. And thank you everyone for listening out there. Thanks, Milton, for having us.
Oh, yeah.
And this has been the Elder Law Report. You want to Perry Mason us out of here.
All right.
All right.
Thank you, folks, for tuning in, and we'll see you again next time, right here on Fridays, the Elder Law Report.
You see how quickly that passes?
It does.
It was like 30 seconds.
Hardly cover anything.
Yeah.
Yeah.
Well, we covered about everything you're
Well,
talking about.
I hope it helps. Like I say, I couldn't say enough about free planning because it really just makes everything just so much easier.
Well, I'd like to get back over there and visit the discharge planners and just, I see what you guys, you're talking about how you're dealing with the families at that same point in time. That's at the same point in time that the people in emergencies come see me too. And they're like, oh
They're
gosh,
scrambling because
Oh, I
they
know.
think
And I'm like, all
they're
right,
going
we'll
to lose
figure it out.
everything.
That's
you know,
right.
They're just scrambling, and I feel so sorry for them because 9 times out of 10, because they've waited, they are going to lose a good portion.
I'm telling you, we can do all kinds of things. I wish I could walk you through some of our plans. I don't do that.
But so that was one of the reasons I was so interested in, what you could do, because lots of people take mama home just because of that fact. They think they're going to lose.
And then mama doesn't
And
get
they
proper
can't
care.
take care of mama.
I agree.
But they don't want to lose everything, or think they're going to lose everything, so they take the home, and then they don't get the care that they need.
No, I agree.
That's the sad part of it. And it's not just everybody says, well, it's not the check. That's the small piece of it. It's the 401k that they've had.
Or the house they're going to
The house,
the land.
the land.
Yeah.
Just
And
things
through
like that.
simple
It's been in
deed
the family for years.
Even emergency deed planning, like Lady Bird deeds, I can save the house and land connected to it right there.
Yeah.
Even if they have to roll Medicare.
So that was one of the reasons I was really so interested in having you come to talk to the girls.
This area of law is totally different than anything I practiced before, several years ago, before I started doing it. And I was amazed once I started getting into it, just number one, how much I liked it and the strategy of it. And number two, how many available options there really are out there for seniors or families to save money and profit. Even in the face of when everybody else is telling them, you just have to spend all your money. The house.
Well, I went through the same thing myself with my brother. He had cancer. And he needed a bone marrow transplant. I needed Medicaid for that. But he had a 401k and everything, and I didn't know that anything like this was available.
Right.
And so we spent his money down. Because what else option do you have? You're looking at a $500,000 treatment. And he didn't have that, but
right.
And he didn't want to. And the thing about it is, what about when you get over this crisis? What are you going to live on if you've gotten rid of everything? That's what I thought. If he's cured, we've gotten rid of just about everything he had. Now what? It has to start over again.
I get it. And
it was a shame.
As much as we need the health care, it costs money.
Yeah.
It costs a lot of money.
Yeah.
So yeah, I appreciate it.
I appreciate
We're
it.
running a CD if you want it.
Okay.
I'll mark. I'll write on there.
I think my director wanted to know if we were going to make one. I said, oh.
Oh, we have a Sharpie or something.
Let's see, there's one right here. Yeah.
It's the 29th today.
Mm-hmm.
Yeah.
Well, I appreciate
Thank you,
it, and
Sybil.
I'm hoping some of your listeners got something out of it.
I hope so too. I think they did. Thank
And
you.
it was nice meeting you. Thank you.
I'm sure we'll see you soon.
Okay.
Thank you, Milton.
Yes, sir. You're welcome.
Thanks for tuning in. We'll be back next week. Who do we have next week? Let's see. Next week we'll have the Hospice Veterans Community Liaison. Dr. Terry Floyd will be on. He's also a chaplain. So we'll talk a little bit about hospice and veterans.